the way to ensure success is to know about perennial disease. And never heard of perennial disease. That was great, great lecture. Steve, I was just telling him every time he talks, I learned something new. All right, approaching the NIVL patients, how to ensure success. These are my disclosures. So if you look at the outcome on the non-thrombotic patients, and this is the data from the pivotal venous studies, and I want to draw your attention to the outcome of the non-thrombotic patients, both 1 year and 3 year. They're pretty good. They're all above 95, 96% patency. So the question is, well, the data is, so excellent, so why worry about success? And so we are already successful, so what are we talking about? Until we sort of dig a little deeper, the majority of reported, if not all, stent migrations happen in NIVL patients. There's about 4 to 5% risk of stent obstruction in 1 year, increasing by about 1% or so per year, so it's not that benign. In this patient population, alteration of the natural history of the vein has to be weighed against benefits. So you see where I'm getting at, is that you have to make sure that the lesion is symptomatic before you put a stent in there, because not only is you predisposed to migration, but you also change the natural history of that segment of the vein. Common iliac vein compression is present in a lot of patients, very common, and potential for harm, therefore, in that many patients is real. Indication for a stent placement in patient with NIVL symptomatic obstruction. Obviously, we've talked about it, you all know. Lower extremity venous stasis symptoms are common, and so is iliac vein compression. We just have to make sure that there's a correlation. This issue of 50% of stenosis, I think, needs to be retired either by area or diameter. Just because somebody has 50% of stenosis doesn't mean that it needs to be treated. So exercise caution. Now let's look at some technical considerations to improve outcome. Confirm presence of the lesion, obviously, by IVUS. Now, stent type, we prefer dedicated nitinol venous stents, diameters, various lengths, and all of that, exist. So the question is, what do you use as your reference? Do you use external iliac vein, or use the mean, longest, smallest diameter divided by 2 plus 2? This is typically what I use. And a rule of thumb for stent diameters, in the common iliac vein, please don't use anything less than 14 and the external less than 12. Wall stent, remember, behaves very differently, so be careful. Technical considerations, stent length. NIVL, by definition, are short lesions. The length of the common iliac vein should be covered. I think we all agree. Should the stent be extended into the external iliac vein? The people who do that, really, there's two classes. One that learned this thing from the wall stent days, and wall stent inherently was not as secure, and therefore extended it all the way down into the external iliac vein. And those in patients that need an anchoring. So if you look at our colleagues, it's a very respectable and well-informed group of our colleagues who wrote the consensus statement on management of non-thrombotic iliac vein. And their number 4 recommendation is stents for NIVL should be extended into the straight portion of the external iliac vein to limit stent migration or other complications. If your stent is going to migrate, that patient doesn't need a stent. There's no lesion there. To say that you need to go into the external so it doesn't migrate, it just means that it means that you are treating patients who don't need the stents. If you look at this patient, for example, with severe compression of the common iliac vein, which is not as obvious on the venogram, and if you look at the sort of a lateral or oblique view, this is the length of the common iliac vein, and this is the external iliac vein, and you can see where the internal iliac vein is. This is where we don't want to end the stent. And so the issue of extending it into the external iliac vein is not just because you want to make it secure, it's just you don't want the end of the stent extended into the curved portion. Now, in practices like ours, placing stents in the NIVL is highly uncommon. I think we've done less than 10 in the entire last year. And we only put it in the external, in the common iliac vein. You never see me extend those into the external. That doesn't mean that's the practice elsewhere. Everybody else does it differently, and the outcomes are uniformly good. However, remember that the extension into the external iliac vein, it is more secure, but creates a diameter mismatch between the stent and the vein and predisposed to something called the Poisson effect. And this is that edge crush pancaking. And this has been written in the literature, not as well sort of recognized, but it does happen. And here's a patient you can see, a NIVL patient with a tight lesion right there, very obvious after a stenting. Look what happened just below that. Right? It used to measure 15 millimeter, and now it's compressed to a little sort of thing. This is that Poisson effect. This is a paper by Dr. Farsad in publication in patients with post-thrombotic disease, which this phenomenon is more common in, 77 limbs, and they assessed the mismatch between post-stent envelope diameter and the stent diameter, and there was a direct correlation between patency and that. And you can see the mismatch right there. That's an example of a patient that was stented, and all of a sudden you see that mismatch. And that is correlated to the outcome. And this is why I don't like to extend not the only reason that it enables to extend the stent into the external iliac vein, but keep that in mind. And this has also been discussed and talked about, predisposition to contralateral DVT, although uncommon. All of these patients had closed cell braided stent, and something like Wallace stent, for example. So now post-stent medical therapy to again optimize the treatment, because that is the topic. How do we make it better? Although there's no good data on anticoagulation and antiplatelets, we usually put our patients on minimum of antiplatelets for 3 months. So in conclusion, iliac vein compression is a common finding in general population. There's potential for harm if a stent place is inappropriate in a patient who doesn't need it. You've heard it yesterday that different people have different techniques. I think Brooke has puts a balloon in there and injects some dye around it and see if it passes through. Steve Black puts a 12 or 14 millimeter balloon, inflates it and pushes it through. If it goes through, he assumes that correctly that the patient doesn't need any stents. Exercise caution. There's no substitute for good judgment in optimizing outcome in this patient population. Thank you.
I'm going to make one comment, Mahmood, is that like being on the safety committees for all 3 of the companies with stents, there were stents in patients with severe lesions that were short, that migrated a lot more often than the long stents. So on safety panels of multiple interventionalist vascular surgeons and cardiologists, that recommendation comes from those safety panels suggesting that the stents, if you have to put the short stent in and make it big enough, they get a lot of back pain. But if you match the size at the top and oversize at the bottom, then you don't get that Poisson effect.
Yeah, and you know that we've been doing, I personally have been doing it over 30 years, and never seen a stent migration in our practice. Probably over 1,000 cases. You just have to make sure that the patient, in fact, has disease. If the patient has disease, the stent stays.